Our next speaker will be presenting on sexual health for patients with bleeding disorders. Dr. KATZ has more than 2 decades of experience counseling men and women and their partners who are experiencing sexual and/or relationship issues as a result of cancer treatments. She's the author of 16 books, including textbooks for healthcare providers and self-help books for survivors, including young adults and caregivers of people with cancer. Now in private practice, she continues to advise and educate cancer survivors and others experiencing sexual and relationship challenges. Please welcome Dr. KATZ.
Thank you. Always a challenge to stand behind a very tall lectern when you're a very short person. So you'll probably see a tiny little white blob at the top. So thank you for this invitation. It's rare for me to actually speak at a conference in Winnipeg, so it was actually a pleasure not having to do the, Uber to the airport, plane, Uber to the hotel, etc. So I just drove here myself. It was great. So I've actually divided my talk into 2, so I'm going to address issues related to hemophilia and then related to blood cancers, so as not to confuse issues, even though there really are a lot of similarities. So as most of you should know, because you're the experts here, not me, there can be essentially physical changes related to hemophilia in terms of bleeding, muscle issues. So this can limit movement, cause pain, and pain associated with being sexually active really applies to a very small percentage of the population. Most of us don't want to experience pain with sexual activity. We know that some people will actually bleed as a result of the friction, and I'm a huge fan of lubricants, so just sort of a fair warning, if any of you are sort of a very gentle persuasion, you're going to maybe hear things that you don't normally hear. But I'm not going to ask you to all say vulva or penis out loud, so just be grateful. So trauma associated with sexual activity, and I'm not just talking about penetrative sex, I'm talking about sexual touch, etc. And certainly, individuals with chronic pain very often notice that their desire is actually fairly low because, why would you want to do something that causes pain? Most of us really aim for pleasure related to sexual activity. Certainly somebody dealing with hemophilia, living with hemophilia, as well as their partner, will experience some challenges related to emotional and social issues. So certainly if you have a negative body image, and many of us in the audience here today, particularly women, will relate to having a negative body image, which results in us doing some really interesting things like dressing and undressing in the bathroom or walk-in closet, avoiding being naked in front of our partner. This is about confidence, it's about self-esteem, it's about sexual self-image, and this can be negatively affected. Even though I think we have come a long way in addressing issues related to hemophilia and how it's transmitted, there can be concerns and fears, and I think certainly the speaker before me really talked about this in a really interesting way, that he had spoken to his assuming potential partner before they decided to have children, to really proactively address any issues that they may have. Communication is one of the most important issues in sexuality, and sometimes I refer to myself as a communication counselor rather than a sexuality counselor, because really it is about talking, and I'm going to speak a little bit more about that a little bit later on in terms of the importance of talking to healthcare providers, and more importantly, healthcare providers, those of us who are involved with caring for people with hemophilia and certainly cancer. I believe it is our duty and our responsibility to talk to our patients about the changes related to these conditions and treatments. And certainly there may be mental health challenges which can also impact on sexual health or sexuality. So when we look at the hemophilia population, there are a number of unmet needs. And this speaks to the responsibility or lack of responsibility of various healthcare providers. So this is a study from 2021, which I guess is now 5 years ago, no, almost 5 years ago. I always say, oh, this is a recent study. I'm not sure if 5 years is recent anymore. So just 33% of physiotherapists, very, very important members of our healthcare team, assessed sexual health or sexuality in the people that they cared for. Almost 2/3 of physiotherapists had not received any training, and this actually goes across healthcare providers, nurses, physicians, etc. A little bit better in terms of people wanting more education, and hopefully that would then influence their practice. So almost all of the social workers surveyed said that it would be really helpful if they had further training. And I spend a lot of my time traveling around North America and beyond, really encouraging various healthcare providers to actually talk about this. And I'm going to talk about why healthcare providers don't want to talk about this. And there we have from actual people living with hemophilia, 50% of those surveyed in the study said that their sex lives had been negatively affected. And only one person in this study had talked to their doctor or their clinical team about sexuality. I just think that's awful, and really a sign of neglect. You know, we talk about all kinds of yucky stuff, and I don't know why we're so reluctant to talk about something that is really focused on pleasure and is an important part of quality of life for all of us. So a little bit about hematologic cancers, where, frankly, I've had much more experience than with people with hemophilia. Here we see that those who had had an allogenic stem cell transplant, 72% of men had profound erectile difficulties. And that's not just about achieving erections, but also maintaining erections. Graft versus host disease, which can have genital manifestations, both internally in the vagina for women and externally on the skin of the penis and scrotum for men, causing body image disturbance as well as irritation and pain. And this, I think, is just absolutely fascinating, but very, very sad, that about 1/3 of young men who had childhood cancer, something that they may not even remember, had at least one problem related to sexual function. And very often, you know, we don't think about a distant cancer as something impacting on somebody's life in the present time. So cancer treatments are what cause the problem. So radiation, because it damages nerves and also blood vessels, impacts on things like arousal, lubrication, certainly erections as well. And then with chemotherapy, not only do we see graft versus host disease, but we also see the impact of steroids, which can result in the development of stretch marks, which unfortunately do not go away. And I have certainly cared for many people who have significant body image issues because those stretch marks remain because of that rapid weight gain that often comes with steroids, and certainly endocrine disruption. So this can impact on fertility, but also on the sex hormones that make sex possible and comfortable. Very often the individuals most affected by blood cancers are adolescents and young adults. And the experience of cancer in these young individuals is known as a biographical interruption because it impacts on the individual's normal milestones that they go through. So think about somebody who has been in hospital for a significant period of time because they're going to have a stem cell or bone marrow transplant. There's this gap in socialization. So, you know, if somebody's perhaps 17, 18, it impacts on their high school experience, perhaps on their university or college experience. And so there are missed opportunities for the things that we do when we're 17, 18, and 19 years old, the sort of semi-harmless flirting, the establishing of relationships. So there are missed opportunities to meet a potential partner. We also see delayed or diminished maturation in these individuals, so they sort of exist at a slightly lower age in terms of maturation than their peers. If this occurs while they're in middle school or high school, they miss sex education at school, such as it is. I firmly believe that sex education really should happen in the family with family values, but sometimes those family values don't allow for adequate sex education. So perhaps that should come with brackets. And certainly overprotective parents. So I think the worst thing that can ever happen is for a child to have a life-threatening disease, no matter how old they are. And it's extremely common that the parents of these young people really are hyper-involved in their child, and I use the word child just not that they're a child in age, but they're still a child, lack of distancing, sort of diminishing independence, excessive worry, and that certainly can impact on the child's sexual identity. If you infantilize a kid, you may be very nervous about them dating, etc., or becoming sexually active. So one of the things that I really want to stress, and how many of you are clinicians? Sorry, just show of hands. How many people are clinicians? Okay, a fair number of you. How many of you are really comfortable talking about this topic with your patients? Be truthful. Who's super comfortable? Few hands, be brave. Okay, a couple of hands. Some, well, you'd do it if your manager or supervisor was like watching. Yeah, and who would rather walk on hot coals? I see you. So I found this actually relatively recently, this sort of diagram, and I actually found it really useful. I'm going to present you with some models in a couple of minutes, which are a lot more specific, but I think, some of us actually do this instinctively with all kinds of things. So the first thing is, to check in with the individual or patient, see how things are going, and you really don't have to use words like vagina, vulva, penis, scrotum, because, honestly, it's just terrible if you blush. The patient is never going to believe anything you say after that. I've been doing this for actually 25 years, which I started as a child. I keep forgetting how old I am. It's sort of interesting. Lost my train of thought. You don't have to say any of those words that are potentially embarrassing. You can actually say things like, how's your relationship? What has changed since your treatment or your diagnosis? And that just opens the door and indicates to the person that you're actually willing to talk about the relationship or the fact that the individual is single. How are you finding dating life? Easy? Difficult? Want to talk about it? If the individual doesn't want to talk about it in that moment, because often they're just absolutely shocked that somebody has raised the topic, they will come back when they are ready to talk about it. They know that you are the person to talk to, which is not a burden at all. It is actually life-affirming, and really, if I've learned anything from working in this field for 25 years, is that I have just learned so much about humanity, and it's really humbling, and has certainly enriched my life. Affirming really talks about validating and normalizing what the individual has gone through, and that's really important because generally people who are experiencing sexual difficulties as it relates to a disease or treatment, they feel completely alone in the world because nobody's talking about this. And I often see patients who come to me with something that I've seen over and over and over again, and they say, have you ever heard of anyone experiencing this? And sometimes I have to tell a little white lie because sometimes what they're experiencing is maybe a little bit interesting, shall we say. And I'll say, oh, yeah, I've heard about it. Inside my head, I'm going, oh, my goodness, now what? But, I'm a nurse, so I have this blank nursey face. They can tell me anything, and I'll just go, that's really interesting. clarifying. So this is where you want to make sure that what you understand by what the person has told you is accurate. And sometimes, we've got stuff going through our head and we can actually miss things, misinterpret things, and oh my goodness, we often make assumptions. Can that be true? Yep. And then finally, I'm not sure that we always have the answers, but it's important to also say, I don't actually know the answer to that. So I'm going to ask a colleague, or I'm going to look it up on the internet. And by that, I don't mean Dr. Google. I mean, we're really not sure where Dr. Google got their medical or nursing license from. It could be now very, very helpful using ChatGPT. I've recently started asking ChatGPT questions, and I'm actually quite amazed at the results. And I actually have a new bio, which I should have given you, because I saw a prompt, how can I make a bio that's interesting and exciting? And it actually gave me a really good bio. So I don't want to burden you, Patty, at this late point, because I only did that yesterday, but it's going to be the bio that I move forward with. So ChatGPT can really be helpful. And there are other AI tools that can use that will actually give you references as well, so really useful. Or you can just hit PubMed and actually look up what the research tells you, or up to date, depending. And I'm very proud that I have co-authored a chapter in Up to Date with a medical oncology colleague. So if you don't have the answer, at your fingertips, you can always find it. And I think it's way better to actually say to a patient, you know what, I'm going to look that up, or I'm going to ask somebody who knows, then kind of muck your way through it, right? Because their detector for nonsense generally is quite high. So, but I kind of like this, and you'll see similar themes in the models that I'm going to present. And please, often I'll say model, and I can see people's eyes roll backward. Models are really helpful, I believe, in just forming a skeleton upon which we can have conversations, particularly sensitive conversations. Before I get to that, I'm going to talk about the things that, I most often hear when I ask healthcare providers why they are not talking about this. So here are some of them, and you could probably add some more. The first that I often hear is embarrassment. We are all sexual beings, but that doesn't mean that we're experts in human sexuality. It just means that we experience being sexual beings. And people are really afraid of being embarrassed. They're also afraid that they won't know the answer. And the blame here is really on medical colleges and nursing colleges, and probably social work programs as well, that the education of healthcare providers on sexuality is woefully inadequate. I have a colleague in the US who's actually done a survey of many medical education programs in the US, and the average is 2 hours in the entire medical education, and people don't get much more when they're interns or residents or fellows, because their mentors and attendings are just not talking about it. The same thing for nursing, and I understand that there's an explosion of information and knowledge that we have to somehow take in, and I suggest that it's not about what we know, it's about how we need to look up what we need to know. So lack of knowledge is a big one. Lack of time is another one. And I see Dr. Houston's here, and I'm going to talk about a colleague of ours who, when I first started working at CancerCare Manitoba, one of the radiation oncologists, was a little bit he gave the appearance of being a little bit crusty, but had a heart of gold. He told me that, he said to me, before you came to work here, and I was doing the sexuality counseling piece sort of off the side of my desk. My appointment was actually as a clinical nurse specialist, helping men newly diagnosed with prostate cancer make a treatment decision. But I'd already started doing the sexuality counseling in private practice. So he said, before you came to work here, I would never ask a patient, and he worked in the GU and GI disease site group. So, treatments to the pelvis that fundamentally affected sexuality. So he said, I would never ask patients because I was afraid that I would be stuck in that room for 45 minutes and there was a waiting room full of patients and everyone was getting irritated with me, so I wouldn't ask the question. He said, so, but now that you're here, I will actually ask a question, and if the patient just opens their mouth to respond, I'll say, stop, you need to see Dr. KATZ. which I was grateful for, because at least people had the opportunity to get information. And I really liked him very, very much for being brave enough to actually do that, because not all of my oncology colleagues did. Not you, Dr. Houston, right? Certainly lack of privacy or privacy. I'm originally from South Africa, so I always get that one mixed up. I haven't learned the Canadianization of that word. And I hear this a lot from nurses who work in chemotherapy units. You know, that patients are often not in a private space, they're in an open space, and they're sitting next to each other in those big chairs. And, you know, how can we talk about that in front of other people? Well, you know, we don't talk about financial toxicity, and we don't talk about, you know, inadequate housing, and we don't talk about end-of-life care in front of everybody else. We find a private space to talk about it, whether it's in a broom closet or on the way to the bathroom. We find a space that is private. But my answer to this is, if you have a general statement, and I'm going to give you some of those general statements in a moment, you can actually say that to a patient within earshot of the other patients, because then they will know that what they're experiencing is a common experience, and they will also know that you are the person to come to if they have a concern. You don't have to have an in-depth assessment of what's going on, but just saying, you know, and you'll hear some of the sentences that you can say, it alerts the patient that, you know, what they're experiencing is common and there's someone that they can talk to. And of course, none of us want to seem weird or intrusive. I don't particularly mind, because I have a way of phrasing it that hopefully is not that weird. Might be intrusive, but it's coming from a really good place, and I think that's really important to know. So to phrase that in the context of quality of life and normalization of all of us as sexual beings. So here are a couple of models that can be used. So this is the 5A model, which actually comes from tobacco cessation. I have flipped the first two around because that's what I like to do. Also because I think if you assess something first, as healthcare providers, we tend to talk at our patients a lot. So if you assess first what is going on, you often don't give the individual the opportunity to actually ask any questions that they may have. So I flip those two around. So ask, how's your relationship? Have you noticed any changes in your relationship, in your connection with your partner? Or if you're brave enough, have you noticed any sexual problems since you started treatment or since your surgery or whatever? And then you assess what that means. Women in particular come to me and they say to me, I'm dry down there. And my response to that is, down there is like Australia. It's a really big space. And if I'm to help you, I need to know if the problem's in Perth or Sydney. And I'm often alarmed at how little individuals know about their anatomy. Men and women. So sometimes, we have to have a little biology lesson, and that's okay. And instead of embarrassing the patient, hopefully I've sort of, made them maybe smile a little bit at the Perth or Sydney reference, and then we can talk about exactly where the problem is or what they have experienced and what the impact has been, and that will help me direct where we're going to go with this. So the next step is advise, which is really about patient education. It's about discussing options for treatment if they exist, and unfortunately for women, certainly, there are few interventions. Men a little bit more because, we have those magic pills. They're not magic. They work about 50% of the time. Then it's important if it's outside of the scope of your practice, which is absolutely acceptable. Instead of bungling your way through in an area where you really don't have confidence that you know what you're talking about, help the patient to find resources to help them. And that may be a book or a pamphlet, it might be a website, it might be a support group, it may be a social worker, another one of your colleagues, it might be a specialist, a gynecologist, an endocrinologist, a urologist, a psychiatrist perhaps. So assist them in finding the help that they need if you are not able to provide it, and then arrange for follow-up. And I think we often neglect to do this final step, because in bringing the patient back and saying, how did it go with the person I referred you to? First of all, when they tell you what they learned, it'll help to educate you. It's also an opportunity to perhaps address some misinformation that the patient might have taken away from that interaction. But it is also really helpful for you to know who to refer to in the future. Because if the patient says to you, I sat in that person's waiting room for 3.5 hours and then I saw them for 10 minutes and really, I'm no further ahead, just try not to refer them there again. And you'll see in the next couple of slides, I provide much more intensive or specialized counseling to patients. I do not expect any of you to do that without a lot of further education. But certainly, you need to know the basics. So this is actually from the nursing literature. So you'll see the final step is document, because, nurses ingrained in us, if it's not documented, it didn't happen. So here is this opening statement that you can use. Cancer treatment or treatment for hemophilia or surgery, whatever, wherever you're working, can affect your sexuality, if you don't want to say that, your body image, your relationship. And these are all important for quality of life. So you've normalized it and situated in something that everybody can relate to. Ask what the issues are. So we're seeing some similarities here with the 5A model. Resources and referrals, just, sort of have in your mental pocket, if such a thing exists, where you can refer to and what resources you have for the patient, and then finally to document. And documentation is important, both to remind you that you've had that discussion before, and also to show your colleagues that you've had the conversation, so that they know that you've set an example for them and that perhaps you're the go-to person. So this is a much more in-depth model or tool developed by Soanes and White. They're from the UK and have worked in the adolescent and young adult space for many, many, many years. The UK is about 25 years ahead of us in North America in terms of treating young adults with cancer. They've developed programs. They have funding for really interesting stuff, and both Isabel White and Louise Soanes work in this space. So here they've asked, over the past 12 months, has there ever been a period of 3 months or more where you had any of the following? And you can see that there are some real sort of nitty-gritty questions here that you can ask, obviously depending on if you're talking to somebody who identifies as male or female. I think this is something that perhaps is more appropriate for somebody working in the sexuality counseling space than perhaps if you're not, don't have specific education or training. But I think it's a useful tool because it addresses both physical issues as well as emotional or psychosocial issues. So I want to leave room for questions because I know you all have a lot of questions, right? Please don't be embarrassed. There's nothing that I haven't heard before. And if I haven't heard it before, I'll pretend that I have. So, if you can remember this, that your patients, whether they're individuals living with hemophilia or somebody who's a cancer survivor, they're going to be, just make the assumption that they're going to be having some sexual difficulties. And just because they don't raise the topic doesn't mean it doesn't exist. We know from research in the cancer space that oncology care providers wait for our patients to raise the topic, to raise any concerns that they may have, because we don't want to be seen as weird and intrusive. And the patients wait for us to ask, because we tell them about all the other side effects of the treatments we provide. We talk about things like diarrhea and constipation and anal fissures and all kinds of kind of yucky stuff. But if we're afraid to say, you may be experiencing changes in body image or issues with sexual function. So they're waiting for us to raise the topic, and the result is a deafening silence. And the first textbook that I wrote for oncology care providers was called Breaking the Silence on Cancer and Sexuality. It was published, oh my gosh, like a long time ago, sometime in the early 2000s. Subsequently, I've actually revised that. Because things have changed and we've actually seen more research in this area, which is really heartening. And I do believe that we're actually moving the needle on this. But that deafening silence, it really does a disservice to our patients. So we need to put on our big girl panties and big boy underwear and actually learn to ask the questions. And you can practice with your colleagues. You can practice with your family members. You would be probably horrified at what I can talk about in the grocery line, because my husband says I have some sort of sign on my forehead that says, "Talk to me about sex." I even have interesting conversations with US customs and immigration officials. Sometimes, they'll say, like, why are you entering the States? Well, I'm going to a conference. What conference? And I have to think about it. So sometimes I just say, oh, it's an oncology conference, because they kind of, it doesn't always shut them up, right? Because sometimes I have to hear about their father-in-law's cancer, which I know nothing about. But at any rate, I'll just listen. But if I dare say, oh, it's a sex therapy conference, it actually shuts down the conversation, which is interesting. But it can also open up to stuff that I really don't want to hear about from a US customs official. Anyway, we need to be talking about this in educating the professionals who are caring for these individuals. We need policy around this, and we absolutely need research. And I really fear for my research colleagues in the US who have been working in this space and are not going to be able to continue with their research. So it's time for Canada not just to raise up our elbows, but I think also to stand up and start funding research decently. Thank you, yeah. And the same applies to the oncology, the heme-oncology sphere as well. Time for questions. If there are no questions, I'll just go home and change into something comfortable. I haven't worn a suit for a really long time. And I'm much better with my stretchy Lululemons, I can tell you.
Walter Carr, very nice presentation, and we don't talk about these sort of things commonly, as you mentioned. The one thing that I would have a bit of a reservation, I'm a pediatric hematologist. Talking to a teenage woman or girl, there's that sort of barrier where they may think this is an inappropriate conversation. And so that may go back to you. So what we do is we refer them to the OB-GYN service if they have bleeding problems, and that makes it a bit easier.
Yeah. So OB-GYN education is also woefully inadequate in terms of sexual problems, just fair warning. I think what you then do is say, I always talk to my patients about, and is it okay if we talk about it?
Up front.
Right. Sometimes it's actually the parents who are most concerned and don't want you to have that conversation with a young person, because as difficult as it is for many of us to think about our parents as being sexual, we're also super reluctant to think about our kids. Even those in their early 20s being sexual beings and being sexually active. So just really sort of prefacing the conversation with a question, is it okay to talk about it?
Yeah, okay, thank you.
Hi, Anne. I'm Christine from Manitoba. I have a question about our community. Because we have a pediatric program and an adult program, some of the staff move between both programs. And because it's hereditary, we grow up with all these amazing people, and they become part of our family. So having these conversations with them is kind of like talking to your mom or dad about it. So there's this little bit of awkwardness because of the familiarity. So I'm wondering, from the patient organization point of view, what sort of messaging can we give our members, and what message would you give to the patient group to make them feel that this is really an important conversation to have?
I think that's a great question. I would certainly phrase it, from the perspective of quality of life, and maybe say we are all sexual beings, particularly as we grow older, and sexuality is just part of who we are. It's how we see ourselves. It's who we relate to. It's who we choose to love and who we choose to be sexual with, and those are often two different things. And so, if you have any questions, right, feel free to ask me and I will help you to find answers. I think the other thing that we also need to think about is the ageism that is so dominant in our culture and in our healthcare systems as well. Too young for sex, too old for sex. I'm embarrassed to say that when I was in my 20s, I don't know why people in their 40s and older kind of bothered, because everything's all jiggly and wrinkled. I was wrong. But we also assume, that people in their 70s and 80s aren't sexual. And they are. And there have actually been some interesting population-based studies in the States out of the Kinsey Institute that show that people in their 70s and 80s, if they have a partner, and that's really important, are doing all kinds of stuff because they got a lot of time on their hands. And it may not be, when you talk about sexuality, I think our brains automatically go to sexual intercourse. And it's way, way more than that, right? So people are doing things that probably are more like what hopefully teenagers are doing and not anything else, which, provides pleasure. So we've also got to be careful just assuming. And also we often leave out single individuals. We think of them not as being sexual, and they are. So that's important too. That's a great question. So just really normalizing, situating it in quality of life and opening the door, not launching into, a lecture, because that's where you turn people off.
Hi there, Dr. KATZ. I think that was a great presentation, so thank you so much. My name's Karen. I'm a social worker in Saskatchewan. We have a history in the bleeding disorders community, of course, the tainted blood tragedy. So a lot of our people who were coming of age or young adults in that time have the added stigma of HIV and hepatitis C. And of course, at that time, from what I've heard, it was very much linked. So the dating world would be extra difficult. Of course, we know that that's the time of identity and exploration. Social relationships become really, really important. I guess this may be a complicated question, but do you have any advice or any recommendations for people who kind of went through that and are having a hard time and have some feelings of maybe anger or resentment, or are having a hard time kind of processing that loss of exploration of identity and sexuality during that time period?
Yeah, I actually worked in HIV/AIDS care in the late 80s and early 90s. So very much a part of, that whole thing. I think acknowledging those feelings and perhaps even raising them without waiting for the individual to talk about them, because sometimes, there's a lot of shame associated with it as well. So raising the topic and listening more than anything else. I mean, if there's one thing that I have learned in working here is just to keep my mouth shut when I'm with a patient. And I think we just, we have this sort of impulse to jump in, sometimes to ease our own embarrassment, but just ask questions and listen and validate. And acknowledge that, they have sort of come of sexual age during a really difficult time. Where there really was this, sort of sea change in terms of safer sex and having to talk about this in a very real, and honest way, whereas generations before really didn't have to talk about it. So I think, just really, asking the questions and then waiting for the patient to break the silence. Yeah. Any other questions? I'm 1 minute over time. So thank you all very much. Here's a question.
So quick. Hello, thank you for the great presentation. My name is Tatiana, I'm from Serbia. And I want to ask you about parents' perspective. I'm the mother of a hemophilia patient with severe hemophilia. And all the mothers want to know what will happen with their sons when they're 13, 14, 16, or, nobody speaks about that. Okay, I grabbed one young hemophilia patient and said, please tell me what's going on. But it's only me officially. Is there some kind of if I could say, prophylaxis for the teenager to prepare them, the kids, what could be the problems in the sexual life further, etc. Something like that.
Yeah. So I think, with a younger teenager, you really do get into that area of, is it appropriate to talk about, are the parents going to be super annoyed? Am I overstepping my bounds? And I think this is where you really collaborate with families, because the parents may be in denial about their kid becoming sexually active, and they are. Right? And I'm just, I'm super grateful that I raised my kids really before, the internet and porn on the internet, et cetera, became so ubiquitous. So we had the opportunity to talk about it in the context of values. And I think in terms of parents of kids who have hemophilia, to talk about it in the context of their disease and work with their healthcare providers to say, what should I be telling my kid? Right? Who should be telling my kid? Because you don't want their peers to be telling them, because the misinformation and the nonsense that happens there, and it's, a lot of it is coming from the internet, is really dangerous. So I think a collaborative approach, because you don't want to offend anybody, but on the other hand, it's really important that young people have information about what is safe and what is not safe, and how, the condition can affect them. No magic bullet here. I mean, it's about communication. Right? And we have to be brave. Okay. I'm gone. Thank you.